Hi, everyone, and welcome to today's webinar, Bringing Lawyers onto the Health Center team to promote patient and community health, which will focus on the different types of funding in MLP, medical legal partnership, the components of an MOU, and sustainability. My name is Danielle Rahajasan, and I will be running technical assistance on this webinar today. In just a moment, I'll turn this presentation over to our panelists, but before that, I have a few small housekeeping things I would like to run through with everyone. Everyone did join in muted for today's session. However, we really do encourage you to type in your questions in the question box or the chat at any time at all during the session. We do have office hours attached to today's presentation, so maybe around 2 p.m., so please stay for that, as it will be an opportunity for us to connect and have a rich discussion around the topic today. And to make our presentations more easily accessible and inclusive, you'll notice that we opted for more text or imagery on our slides. There will also be a very brief survey that will launch at the end of this webinar. Your participation and responses really do help us learn more about your needs and how to continue to improve. We also have 4 handouts prepared for you today, which were automatically distributed to you and will be referenced throughout this webinar. Today's audio recording and slides will be made available by next week on the webinar page of our website, and we will share that link with you also shortly. We do want to acknowledge that this project is supported in full by the Health Resources and Services Administration, and that the contents are those of the authors and don't necessarily represent the official views of HRSA, HHS, or the US government. So before we dive deeper into the content, I really wanted to quickly reintroduce you all to the National Center as the leading voice for leveraging legal services inside health organizations. The National Center for Medical Legal Partnership really leads education, research, and technical assistance efforts to create conditions where all health organizations in the United States can leverage legal services as a standard part of the way that they respond to social needs. So in the move toward value-based care, this is really a time when there's a lot of focus on social determinants of health. So MOP is really an approach that can help with some of the most complex needs. So the toolkit that we will be referencing today could not have been developed without the help and contribution of our expert panelists who will be joining us today. We will be joined by experts from Indiana and Montana. So first, Beth Robel, who has been the CEO of HealthLink since 2002. She has moved the organization from a free medical clinic to a FQHC, providing a healthcare home to all life cycles, prenatal to seniors, with integrated medical, dental, optometry, and behavioral health services at 15 locations with 450 employees. She is on various boards, including the Indiana Primary Healthcare Association, State of Indiana Graduate Medical Education, Ivy Tech Valparaiso, Michigan City Campus, the Indiana Cancer Consortium, and Managed Health Services. She was named the 2014 Not-for-Profit CEO of the Year by Northwest Indiana Business Quarterly magazine, the Outstanding Agency Professional by the Porter County United Way, and the 2017 Valparaiso Chamber Leader of the Year. Beth holds a Bachelor of Science degree in Mechanical Engineering from Valparaiso University. She is also a graduate of the J&J UCLA Healthcare Executive Program. Joining her today will be Raquia Trice, who is the Deputy Director of Indiana Legal Services, a statewide not-for-profit law firm and Indiana's largest provider of free civil legal assistance. Raquia oversees the compliance and day-to-day operations of Indiana Legal Services regional offices and its medical legal partnerships. Prior to her current role, Raquia was directing attorney of ILS's Central Indiana MLP team and operated a medical legal partnership project with a regional health system. Raquia is admitted to practice law in Indiana and is a graduate of Indiana University's Morrow School of Law. On Montana's side, we will be joined by Olivia Riuda, who is the Outreach, Engagement, and Population Health Manager at the Montana Primary Care Association. She joined the MPCA in 2013 to organize and lead MPCA statewide outreach and enrollment activities. Prior to joining MPCA, Olivia was the co-director of Montana Women Vote, planning and implementing civic engagement, field campaigns, and advocating on issues that impact low-income Montanans. Olivia has a BA in grassroots development from the University of Michigan and is currently a graduate student in public health at the University of Montana. And joining her today from Montana will be Callie Dale Ramos, who joined MLSA as an attorney for MLSA's Montana Health Justice Partnership in 2016. She received her JD from the University of Texas Law School in 2015, where she represented clients during immigration proceedings and served as a human rights law scholar. Before starting at MLSA, Callie was a legal fellow at the Indian Law Resource Center in Helena, advocating for legal reforms to increase tribal sovereignty in cases of violence against women. In 2020, Callie received the American Bar Association SCLAID Centennial Access to Justice Award for her work on the Montana Health Justice Partnership. And finally, by Bethany Hamilton, who is our co-director here at the National Center for Medical Legal Partnership at the Milken Institute for School of Public Health. Bethany has spent her career working at the intersection of health equity and social justice. She most recently served as Deputy Director of State Affairs at the National Association of Community Health Centers, where she led projects focused on expanding Medicaid, defending the Affordable Care Act, and strengthening the ability of community health centers to carry out their mission. So today's webinar will focus on the Health Center MLP Toolkit, which was part of the handouts you received today. The dissemination of this document is through a webinar series, and today's session is part 2 of that 5-part webinar series. So part 1 of the toolkit outlines 9 conversations that your health center team should have together with your legal partners to plan for MLP's long-term success and to integrate legal services into the operations of the health center. And today we will specifically focus on conversations 4, 5, and 9 of that first part of the toolkit. So before we start, I'm just going to launch a poll just to kind of get a better understanding of who our audience is today. And while you respond to it, I will pass it on to Bethany, who will do a very brief overview of what we covered in the very first part of this series.
Thanks so much, Danielle. So first of all, before I dive right into saying where we've been and where we're going in today's conversation, let me take a moment to thank everyone, our panelists and attendees, for really stepping away from the very important work that's ongoing. In particular, I know that the health centers are not just continuing to work on everything from day-to-day primary care, addressing the conditions of their patient populations, but also testing and vaccinations now, really gearing up for the road ahead. So take a moment to click on the poll to let us know what stage of an MLP you are developing or planning or operating or hoping to improve by sitting in with us today. Where we have been in terms of walking you through our Health Center MLP Toolkit is laying the foundation part 1, where we discussed what is an MLP, what is a medical legal partnership, what do we mean by when we talk about those core activities where we embed lawyers in as basically your specialists on the healthcare team to help address patients' social needs. Through MLPs, we know that whether it's from direct legal assistance or all the way up to and including clinical systems changes or policy level changes, that's where we're churning out the results to see healthier patients, stronger health center workforce, and improved health equity for communities. Danielle, I'm going to ask us to jump to the slide where we highlight the 3 conversations. And then next one. And Danielle, how did our poll results look? Great. So we do have a really, really good mix of medical legal partnership folks here today. Many of you, I'm going to go back to the slides now. many of you have already experienced, and even this includes folks who are very new to the MLP and really walking themselves through Toolkit, or you're very much at the beginning stages. You have gone through these conversations, either in considering or with your potential partners, talking about what are those social determinants of health problems that you want to address, how many lawyers may you need, or legal services staff in general, and then how are you going to build it into your medical legal partnership? Are you going to build it in, or are you going to contract it out? So how are you really going to staff that partnership? That's what we walk through in detail in our November Laying the Foundation Part 1 webinar. And today, as we knew would be the case in developing the toolkit and in having the conversations with you, we knew you'd ask the next question. So next slide, please. Next question is, how are we going to pay for it? We definitely saw this coming up quite often in our toolkit presentation last time. Folks had very basic questions around approaching those initial funding stages, all the way to ensuring that all partners were bought in and understood what this would cost. Next slide, please, Danielle. Thanks. And next one. So for today, we're going to explore some of those methods for securing funding and sustainability. We're going to discuss and hear more from our expert panelists from the field about how they develop those strong MOUs or MOAs for some of you to help ensure that you have funding agreements in place, as well as those that are inclusive of sustainability considerations. And then we'll hear about those strategies from Indiana and Montana to actually employ those very methods to get all of this done successfully over the years. And in a few cases, you'll hear some examples about how things are evolving on the ground. Hopefully you'll also stick around, as Danielle mentioned, for the office hours to really get to ask about how those evolutions have occurred as a result of COVID. All right, so let's talk about funding. How are we going to pay for it? If you're following along in the toolkit, go ahead and click on it. You'll see that we do have an entire section dedicated to funding. At the very high level, next few slides, Danielle. I want to show you a roadmap that really helps you travel through an example, just an example of what a typical health center approach to really embedding lawyers through an MLP approach can look like. For the most part, what we know from the field is that the experience starts with this philanthropic investment that involves looking at what the cost of a lawyer would be, whether it's a full-time lawyer, part-time, or otherwise where they're contracted out for services or they're fully embedded in that approach, as we saw during our first webinar in November through the Whitman Walker example, or your hospital-based MLPs. But what we see from the field is that you have that initial investment, and then typically you're moving into some sort of integrated approach where you're looking at your federal grants and other revenue streams to help better support the involvement of that legal services approach. The example that's showing up in the roadmap on the screen involves an Equal Justice Works Fellow, something that I also did, which was supported specifically through AmeriCorps dollars, which are federal dollars. And we know that that comes in a temporary sort of manner. That is a 2-year fellowship. So those are the sorts of things one would need to think about as you then move into your various approaches to sustain it beyond, for example, that 2-year fellowship that may come in to provide the legal services. So you see in the health center example, right, they may go about it through a split cost approach where they're blending the cost over a specific time period, and they're looking at the various aspects of the disciplines involved in the medical legal partnership, such as the time that a physician would be involved in the approach, or the lawyer or other services. I pause and you'll hear me stumble a bit when I just focus on the lawyer because I always want to make sure I'm broadening this to say legal services. And also I want to make a footnote here to ensure that when you're thinking about medical legal partnership approaches, you're also including folks like your patient navigators, your case managers, your social workers, the nurses, all of the other folks that are involved in ensuring that the broad social determinants of health approaches are addressed through your medical legal partnership. Next slide, Danielle. So as you continue in the health center funding timeline and move from your pilot philanthropic investment and your split cost approaches, then you're starting to think really about sustainability. And a part of that conversation, as I just alluded, involves thinking about who it is that is really involved in your robust approach, right? So you'll see an example on the screen, community health workers should be included. You're also looking at the health center costs that are related to running and operating and carrying out those MLP activities. Also, as you'll see on the screen, we make note of Medicaid managed care and the role that that plays in ensuring that you have a longer term approach. Continue to travel through that timeline and roadmap. You'll see that there are references in the toolkit to the types of chronic issues that your MLP may decide to address that very well may dictate how you go about your funding approaches, or how you go about looking at the different revenue streams that a health center may tap into in order to sustain its medical legal partnership. Next slide. So we're going to run another poll to get a better sense from you all about how, in fact, you may be addressing funding sustainability, and then are you including those approaches in your annual budgeting? Are you, in fact, taking steps to look at your revenue sources such as Medicaid? So take a moment to answer the question. The question for this second and final poll is, does your funding strategy include any of the following? Does it include the development of an annual budget? Meaning, are you going beyond just that first year and continuing to review your budget to make adjustments going forward? Are you seeking reimbursement for legal services through revenue streams such as Medicaid? Are you collecting and analyzing the data from all of the partners to know what your actual costs really are? Are you seeking startup funding from private funding from public sources? How are you really looking at that initial funding source? Or perhaps you're very much at the beginning stages in exploring medical legal partnership and you don't yet have a funding strategy. That's okay. That's why we're here today. All right, so hopefully we have some good data coming in on where folks are at. Another good mix, having previously served in the policy shop, I am actually happy to see that the lower percentage here pertains to those funding buckets, such as what would come through Medicaid. That means there might be some further conversations about what payment levers one might be able to, or reimbursement mechanisms one may look into as it relates to funding the medical legal partnership. All right, thanks, Danielle. Next slide. So as we're continuing to have that funding conversation, the next set of conversations really are with the various partners. How do we really look at our MOUs to build into, next slide, what our goals and expectations are for the program, each of the partners who've invested time, dollars, and hopefully also their quality metrics, right? How they're actually serving the patients into their MOU. Hopefully we baked all of this in. Next slide. So generally speaking, if you're looking at your MOU development process, and in the toolkit, we go into much greater detail about this, and our expert panelists from the field will talk to you a little bit more about how they took this on. But if you look at it in terms of like, what's the big hit list here? Really, in your MOU, make sure, what we advise is that you make sure you're hitting on the goals for your program. Make sure you're hitting on the responsibilities across all of the various partners that are involved. Sure, we're embedding lawyers into healthcare systems, but we must ensure that every single partner of the healthcare system, the lawyers, the other legal services professionals, such as your paralegals or your case managers, every detail, even if it's in broad strokes, with regard to the expectations and responsibilities, are included in that MOU. And then you'll talk about how you're going to measure for success. It doesn't have to be a 5-year plan for success. You may not know if you're going to go that long. Perhaps you're piloting for 1 or 2 years, but make sure you're absolutely addressing how you'll measure for success in the end. And a lot of this is driven by the data that you're gathering going into the planning process, that you're gathering along the way, and that you're looking at coming out of it. I can tell you, coming from the civil legal services world, we don't like to gather data. And we know we have a lot of attendees on the line right now who are the lawyers. We don't like to gather that amount of data. We also don't like to analyze it. This is where you're gonna have to swallow that hard pill and figure out the ways that you are already gathering data, look at those case management software databases, and work with the health systems providers, because you very well may have similar data sets or points in that data set that align, so you don't have to do the extra gathering and analyzing of data. But I can tell you, you're going to have to do it if you want to really address social determinants of health the right way, utilizing the MLP approach. All right, so next slide. Speaking of partners, what are the other partners in the community that can be helpful? I do want to emphasize that this is something that you very well should be thinking about as you design your funding strategy, your sustainability approach. As you'll see on the next slide, these are the very folks that you'll also very likely include, depending on the structure of your MLP. These are the sorts of folks that you may include and address in your MOU. So those ACOs, right? If in fact you're working with an accountable health or community of health, or if you're working with your MCOs, the managed care entities in Medicaid, or your primary care associations or state Medicaid agency, find out what their stake is, what their interest is in helping to support this medical legal partnership. Because even if they aren't a bona fide partner, perhaps, right, you are getting reimbursement for legal services. And so you'll want to make sure, right, that you are addressing those aspects in your longer term funding strategy and your MOU, so that all of the partners who are actually addressed in that medical legal partnership know what's coming down the road, because I just emphasized that data is going to play a very, very big role in your measurement for success and in carrying out your sustainability down the road. And there are several other examples. We spelled this out in the toolkit. So speaking of the going down the road, in investing, especially now, right, with, I know health centers are constantly fighting for funding every single year. And this year in particular, where visits went down and revenues went down, and many practices, as a result of either not having PPE or because the visits went down, they had to shutter their doors in their practices, such as dental practices. So sustainability is always the question, and especially if you're in the beginning stages of your MLP approach. Next slide, Danielle. You're definitely going to want to make sure that you are considering how to make sure this program is effective and lasts. It's very, very disruptive to patient/client populations that we all serve, to bring a program into a community and then not think about sustainability and have to remove it. I noted to you all earlier on, right, that a fellowship approach, right, those last for a limited amount of time. And so imagine if you didn't plan ahead of time to replace that legal fellow, which is really effective. Clearly I'm biased, but I can also tell you it's a very effective approach to getting legal services brought into the healthcare systems, but it comes with a limit. So if you aren't planning a long-term approach for continuing to keep that embedded in that healthcare system MLP approach, you are going to actually disrupt care for the patient population that's being served. So some of the factors that we discuss in the toolkit fall into what we borrow really from others who have been developing these processes along the way for evaluating success. They fall into these buckets called the 8 domains of sustainability. I'm just going to quickly overview this though, so that you can hear more from our folks and friends from Indiana and Montana about how this really played into their approach. But just very quickly at the high level, look at and consider the environmental support. Definitely think about strategic planning for your program's directions, goals overall. Think about your organizational capacity, and we have various organizations involved. While this toolkit presentation is really about health centers, some of the medical legal partnerships also include your hospital partners, your free clinics, and other healthcare system entities in their MLP approach. Some folks may highlight some of that in their presentations coming up, but all of them have varying degrees of capacity to take this on and varying degrees of resources. If in fact you really are building an MLP that involves all of these partners, everyone should be able to be transparent about what first of all, what their capacity really is, and transparent about what they can actually contribute to the partnership long-term. Also, I talked about data and analyzing that data. You are going to want to ensure that you are thinking about program evaluation and really assessing and planning for success at the end. That is a cost. You should build that into your funding strategies as well. Also, next slide, please. You're thinking about your communications approach for stakeholders. I often have conversations with folks to emphasize that it is okay when you're in the planning stages to really think about low-hanging fruit, because you want to actually like design a pilot program that aims for showing some successes, right? And so in conversation number 1 back in November, when we presented, we really talked about like when you're looking at the social determinants of health approaches, the way you design your MLP, you may not initially decide that you'll take on all patients and all problems in your approach, right? So those are the sorts of things that you'll want to think about when you're thinking about communicating to stakeholders exactly what it is that you're planning to get done in terms of getting their buy-in and communicating that along the way. Same thing for funding stability, your partnerships, and then program adaptation. You're really ensuring that, you know, this is really about fundraising. That's where I wanted to land on here. This is really about where your development folks, right, at both the health centers, the legal services partners, right, these are your development folks who would look at these 8 domains of sustainability, and they'll say, sure, in the grant writing process, these are the sorts of things we take into consideration when we're planning for any program that we are seeking to adapt and apply to make healthier communities. All right, so with that, I'm going to pause to make sure we have enough time for Indiana and Montana to talk a little bit more about what their MLP approaches are. Before I first have Rakuya and Beth present, I just want to remind folks that please, we'll have office hours, but please in the chat box or Q&A functions, let us know what your questions are. I provided the overview, but you'll certainly hear from Indiana and Montana experts on how they actually carried out these approaches. With that, Beth and Rakuya, I'm going to mute myself and thank you all and pass it along to you.
Thank you, Bethany. Well, first of all, thanks for the opportunity. I think when I started this about 4 or 5 years ago, we had no clue where we were going, of course, because we didn't have a toolbox like Kit, like you have created. So it's been really amazing. But I know I was sitting in your seat, some of you that are in that planning beginning phases, and you know, I can remember thinking it's not going to happen. There's no way. And I think we have a really strong MLP, and it's confirmed every day when I hear from our providers, oh my gosh, we wouldn't be able to live without our MLP, or I'm recruiting a new provider and I tell them about that. And they go, wow, I've never heard about that. This must be a pretty cool place to work. And I said, absolutely. So let's do the first slide. So let me tell you a little bit about HealthLink. It's kind of hard. We're on the North Shore of Indiana. Archaea is at the center part, but we're on the North Shore, Lake Michigan, and really close to Chicago. We are very, well, I guess for Montana, we're not diverse in locations, but for a lot of the health centers in Indiana, we're pretty spread out. So we basically go from the Illinois border past South Bend to Mishawaka and down to a very rural site in Stark County. We have everything that most FQHCs have. A couple things that have happened that I can't say enough that the MLP has helped is that we've started an MAT program. Every site has some providers, and I'll talk about because that's part of the funding too. The other thing we just started in the last year and a half is a mobile integrated response team where we will go out, excuse me, when someone overdoses and it's either at the hospital or the police are there, and we actually have trained peer recovery coaches that will go out. And again, the MLP, it's not, I mean, if they have criminal issues, no, but if they've lost their driver's license because of something, we can work with them to get their driver's license so they can go get a job and be productive. We have 11 standalone clinics. We have 2 school-based and a mobile unit. And we have 1 MLP over all of those sites. Next slide. So I always like to start with the why. And I think back of what happened. I'll never forget, I was it was one of the NAC meetings that was in Chicago. We were there, and I got a call that said that HUD and the EPA were coming into East Chicago, where we have one of our clinics. They were having, because of a lead issue, and they were having a community hearing, and the mayor wanted us there. So we all went on the way back from the NAC meeting. We went to East Chicago, and I got to look at about 1,500 people who were told, you have less than 30 days to get out of your housing because, oh, well, 30 years ago, we built the public housing on a lead smelter. Oh, we also built your kids' school there, and they've been here for the last 30 years. A lot of things came up, and I'll never forget one of the councilwomen, Gilda Orange, came to me and said, you got to do something. And I said, okay, Gilda. Well, I'm thinking I can't clean up the lead issue. And she said, there is an attorney in coming and picking up all the residents in Rolls Royces and saying, you are going to make lots of money over on the EPA. And she goes, you know, I tell him they're not going to make money. He's going to make money on you. And I go, Gilda, I don't know what to do. And I realized that one of our my board chair at the time was on the board of the Indiana Legal Services. And I called him, and he connected us. So that was kind of our first. We really became the why of trying to help these people in East Chicago that had less than 30 days. And a lot of them were going to be sent back to Chicago. Indiana had a lot better. We had Medicaid expansion. They just had moved out of there. Now they're being forced. What are their legal rights? And so that was kind of our first little pilot. To this last year, I never thought when COVID hit that we would have so many issues, a lot of housing. And I'll never forget, the governor had just done his stay-at-home, or the shelter-in-place order. And one of our community health workers had gotten a call from one of our patients. I'm going to call her Susie. She was disabled, living in a trailer, and that she had gotten an eviction notice for 3 days. She had to get out of that trailer. In the meantime, the owner of the trailer park shut off the water and the electric. Here she's in shelter in place. She's in a wheelchair, and she's got to find a place to live. What were her rights? I was pleased to hear, Sarah, our MLP attorney, jumped in, and she said, I thought this was going to be easy, but it took her a week. She got the power, they got a stay order so that until that she could stay in there, the electric was turned back on, the water was turned on. When she was able to go look for another place, she made sure she got her deposit back. Those are the things, and she had multiple chronic diseases. We never could have taken care of her chronic diseases if she was living on the streets. And so those are just two extremes kind of thing, but it really makes us be able to focus. Our MLP attorney, Sarah, takes care of those things, and then our providers can take care of what they're really good at. So that's our why. So next slide. So everybody wants to hear about funding, and I understand that. I didn't know where I was going when I started this either. So when we had the pilot, I will say Indiana Legal Services stepped up and for a little while gave us an attorney that they would have had in their Maryville office to come to our site. But then we worked with a local foundation, and we went to them and we said, and especially it became such a big thing about the lead issue, that they gave us some money to fund the East Chicago. Then the next year, Indiana University has a research arm, and they really wanted to look at MLPs. So they gave us some money to do that data gathering and teach us what was the right data we needed to do to be able to show to funders, and allowed us to expand to other sites. And then we've also gone to multiple, so every county we have has some kind of foundation, and then we've also gone to United Way. We were able to get a SAMHSA grant through our Indiana Department of Health to do integrated behavioral health. And we're able to say, MLP is really important for this integration of behavioral health, especially if someone has a mental illness and they can't get disability or get Medicaid. That's really helpful. And so that's my other hint. Every grant that we go for, we always think, is there an element here that MLP is going to help with? And again, the next year, this year, we've been able to do United Way. When we've been able to have our MAT funds, any expansion there, we've always written the MLP into it somewhat. And then this MIRT, this Mobile Integrated Response Team, where we have the peer recovery specialists grant that we got from the state, we included in that. This next year, again, the same group that we had before, but the interesting happened about a month ago. I got an email from someone at one of the managed care companies, and they said, can we have a call to talk about your MLP? I don't know what an MLP is, she said. And I said, okay. So we had this call, and she goes, oh, we wrote you into our state renewal grant for the age, blind, and disabled. I'm like, interesting. And they go, well, how much money do you want? And I said, but I can only serve your patients that are, you know, or anyone's patients that are just our patients. And they said, that's okay. So we actually were able to get a chunk of money from them. The state, which the other thing I probably should have mentioned, the state of Indiana has really been on our Medicaid director and secretary of FSSA, Dr. Sullivan, has this passion. We're not allowed to call it social determinants. We call it healthy opportunities. And so she's really big on it. So they're starting to really write that into the Indiana Medicaid, any renewals that the managed care has in there. And so that's been so helpful. And again, we've been keeping data. I have one manager that's our manager of strategy and compliance, and she's over our grants. So she's kept data. She talks to Sarah, the MLP attorney, all the time. We've also, in this part, I know I got to watch my time. We also have all the referrals go through our electronic health records. So we're able to then document, and she gives a brief. There's HIPAA and there's the medical or the legal side. She gives us enough to know what's going on, and we put it in the chart. So that's been really important. Next slide. I think that might be it. I'm going to turn it over to my best partner in the world anyone could have in any MLP, the Indiana Legal Services, and Rakia.
Thank you, Beth. I'm going to give a bit of a background on Indiana Legal Services. We are a statewide program serving 92 counties. We have 10 medical legal partnerships, 10 full-time attorneys, and 4 paralegals assigned to our medical legal partnerships. As an organization overall, we have about 180 employees. About 80 of those employees are attorneys, and the remaining 100 or so are support and admin staff. We're primarily funded by the Legal Services Corporation, but about 30 to 40%, it varies from year to year, comes from funding from different grantors and fabulous partners like Beth and HealthLink. With the medical legal partnerships, it began as an organic process for us. We've had MLPs for about 10 years. Now it's actually getting a little closer to 15. And it began when our now director of advocacy started doing intake at a local health system in Indianapolis, and we grew from there. What I like most about our MLPs, and particularly our HealthLink MLPs, is that as Beth mentioned, there are centers and there's an ability to reach patients who are rural. And as a legal aid provider, that's been difficult for us. We are able to reach our metropolitan client base a little easier. And so what we found is that in working with HealthLink, which does an excellent job in making sure that patients are aware that the MLP services are available, that we're able to reach a population that otherwise would not come through our doors, but which have health harming legal issues that need to be resolved. Next slide, please. So in terms of drafting the medical or legal partnership MOU, we start the process about a year in advance. We try to. And what that does is it gives us the ability to have a timeline. We look at how will we introduce it to the partners team, what data do we need to collect to show that we are being successful, and we do include that in the MOU. One, it allows us to set benchmarks for our attorneys and our paralegals as they're doing the work as well. We also talk about who will be the champion for the MLP, who will the MLP attorney contact if they're having questions or they need to know about a particular referral. We also talk quite a bit about the unmet need, the unmet legal need of patients, and that takes time, a bit of time early on to develop. If you do that work early on, I think you start off with a stronger MLP, and that's talking with your partners and meeting with the partners team to hear, you know, I have patients coming in and they're complaining about, you know, their homes not being clean and their landlords aren't making repairs, or they're being denied a public benefit. Those sort of things, knowing early on, we're able to focus on those legal issues and say, this is what we're going to look at, and obviously expanding over time. But it is important to kind of know what those unmet legal needs are. We also focus on what locations or product lines will be have access to the MLP. And so from there, we then use that information to draft the MOU. We do update that MOU as the needs of the patient clients change. But again, it's helpful to have that in the MOU so everyone kind of knows how the MOU is progressing, particularly when it's a new MOU, because you can show the difference from when you began and how you've had success. The other thing that I would say is staffing the MLP. If you have other information about the unmet needs and what product lines, then you have to plan on who's going to perform those services. And I would say that the National Center has great information and links that are connected to the presentation today that to help you decide how many staff members you're going to need, because it really is based on how large the health system is. And then in terms of funding it can be difficult on a standalone grant, relying upon that alone. As Beth mentioned, kind of a hybrid of funding sources is very helpful in making sure that the MLP is sustained. And next slide, please. So I can't stress this enough. Having that partnership with Beth and with HealthLink, you really have to be able to have an open conversation with your partners. Having that strong relationship is going to guarantee, in my opinion, that your MLP is successful. We're both working together. I feel like we're working side by side to make sure that patient clients are getting their health needs and their legal needs met, and that's what's driving our work. I think the best example of this is earlier this year, ILS received additional funding, and so we looked at where we were financially and we determined that we were going to be okay this year. But we also thought about the pandemic and how it's been affecting our partners. And so what we decided as an organization to do is to give an invoicing holiday for the second quarter of 2020 so that our partners, like Beth and like HealthLink, they were able to use their resources to help patients who needed so much help during this difficult time. And there was no interruption in the legal services, the MLP services. I think that speaks to the relationship we have with Beth and with HealthLink and our MLP partners, is that we understand the impact that each of our services have on our patient clients' lives and their health. And so we work together to look for ways to have a positive impact and look for innovative ways to help patient clients, whether that's through policy changes or new programs, that help with things like rent or utility payments for a patient. So what I would say the biggest takeaway from this would be really spend time on developing that relationship with the partner, so that you're understanding what they're seeing on the front line, that you're also talking about what you're seeing coming in, and just building that relationship. And I think that will ensure the success of your MLP. And I believe I will be turning it over to Olivia.
Great, thank you. And you can go to the next slide. I'm going to hand it off to Callie to tell us a little story.
Hi, I'm Callie Del Ramos. I'm going to share a quick story. So we have a screening MLP. So all of our referrals get screened, and then that's how in their healthcare centers, and that's how they end up talking to Montana Legal Services. But I was helping a client. She had gotten kicked off of her Social Security, and I was helping her get back on. And we left the hearing, so she didn't even know the outcome. And she just said, "Who knew filling out that stupid piece of paper would get me an attorney to do this?" And it's truly one of my favorite things that's happened in the MLP, but just how that little intervention that can even feel annoying to the patient clients when they're doing it can have this big impact, and helping them pay for rent and food and all of the other things that they need when their benefits get turned off. So I'm going to let Olivia talk about the actual mechanics of our MLP now.
Thanks, Callie. I love that story. So this is the state of Montana. So I'll just tell you a little bit about our MLP in a nutshell. So we run as a single MLP. We have 8 partners, 6 of them are health centers, and the Montana Primary Care Association, I work for the PCA, and Callie works for Montana Legal Services, are all part of this one MLP. We operate as one project, standard screening and data reporting. I appreciated what Bethany said. We are sometimes unique in that we try to screen everyone for all problems. And so we can talk more about that later. So these 6 health centers serve about 40,000 patients, mostly rural and frontier. A lot of these health centers and their sites are adjacent to tribal communities. These are reservation communities. And so the MLP serves a lot of Indigenous people. The legal team is 1 attorney, Callie Del Ramos, and a half-time paralegal. And this is a circuit rider model, right? Montana is a big state. And this is like pre-COVID, right? The model really is to do mostly phone legal help from Montana Legal Services. And Callie and her team visit each health center about every other month. But that was pre-COVID, and so there's not a lot of travel happening right now. So we're really gonna not talk about the MOU as much, but talk about funding and sustainability and a lot of information about data. So if we could go to the next slide. So, right, the first question everybody always gets is, how do you pay for it? And so I think we are, as Bethany was going through, we're kind of a mix. Our approach was, number 1, philanthropic, right? We got some seed money to do a pilot. We didn't do a study, we just did a pilot, jumped into it. I think that these days, with the resources that the National Center has, which is so much more and so, I think, well organized in terms of starting an MLP, you can jump into it that way. So we got the pilot grant. I think each partner contributed initially from the beginning. We got a second grant from the Montana Healthcare Foundation, and to expand the project and really build towards sustainability. And when we talk about sustainability here, we mean funding sustainability with being a full partner funded program. And so now we're really in kind of the number 3 approach, the split costs. So in 2020, we really shifted into a full partner funded model. Each partner contributes, including the Primary Care Association and Montana Legal Services, like we all put money on the table for this project. And that amount for each of those partners was just under $20,000 each month. And so our project is often called the subscription model, which I think is helpful and also a little deceptive in that, right, we can break off our subscription from Amazon at any point, and Jeff Bezos is going to be fine. I think that with the Montana Health Justice Partnership, we have a really strategic group of health centers that we're working with, and so the partnership matters a lot, and it would be very challenging to the rest of us if somebody broke off their subscription. And so I do think it's a shared funding model where those partnerships really matter a lot. And I will also say, in terms of how each of our centers and the PCA kind of pay for our portion of that, it really depends, right? Some of them are using grants to work on integrated behavioral health, substance use disorder treatment. Some of them are just kind of using Medicaid expansion reimbursement dollars. At the PCA, we have built this into our Bureau of Primary Healthcare grant, both on the PCA side, and then we also have an HCCN as part of our PCA, and it's built into both of those grants, which I think if you aren't talking to your primary care association, you should, because there's some beauty in those 3-year big federal grant. There's some consistency in there that really allows us to do our piece of the work. So I'm going to hand it over to Callie to kind of dive deeper into the role that data has played into getting to this funding place, and then we'll talk about sustainability.
Yeah, so I would say the most important the specific that we had in our MOU was we had really specific expectations for everybody who was signing the MOU to then be at conversations about what was happening in the MOU. So we had quarterly conversations with the CEOs of all of our healthcare centers. And the very first one of that, it was 2 days before I was officially hired for my job, was setting out what were going to be our data deliverables. So we looked at the national resources and we chose 4 things that we were going to, as an MLP, report on. And that was how many patients are getting screened at the healthcare centers. So healthcare centers were responsible for that data. How many healthcare center people were being trained. So we knew that people were going to consistently understand what was happening with the project. And then how many of those screenings and referrals actually spoke to somebody at Montana Legal Services. And then our 4th one was what money is in the pocket of people that we talked about. So if you were a client of MLSA, did you get money in your pocket? So this is just a kind of a look at our data. So in 2019, 13,000 people were screened for legal needs, and that resulted in 872 referrals, and then 400% of people actually received assistance from that program. So those are always things that we look at. We do a lot of quality control conversation with our medical and legal staff about kind of where our gaps are. And then this is our referrals by quarter. So we keep track of how many referrals, and then on the legal team, it helps us when maybe we need to go back in and do another training. So that dip down to 81, we're like, oh, we should probably go talk to people and make sure that everybody knows what's going on. You can go to the next slide. We keep track of cases. And then the big red ball, I think, is important because we were really clear with our medical partners, like we were going to be doing advice and brief services. This is really an advice-centered program. And then, but knowing that that would be something we would have to come back, have conversations about if they felt like what they wanted, what their investment was getting people represented in court. So that's a conversation that 5 years in we're still having, and we have agreed as an MLP that that's what our needs are providing the most services to the most population. But that was something that was part of the MOU and was really important in those conversations, like what the legal team is actually going to be providing. And then I think there's just last one, which is money, which is the thing that MLSA has found to be most helpful in people wanting to be excited about the project and helping them then talk to their boards or whoever they need to talk to on the medical team when it's time to pay that $19,000. So in 2018, for clients who receive services from Montana Legal Services, they got $183,000 directly into their pocket. So that's not like ambiguous cost of like what the value of like not being in a domestic violence situation. This is money in their pocket. And then we also reached out to the State Board of Montana, and they do a survey every year of how much attorneys make. And so then we use that rubric to create an average of what if the patients that have been served by our healthcare centers had to pay out of pocket for those legal fees, how much in 2019 they would have had to spend. And then in Montana, as I think it is common, even if people had money, which our clients don't, there's often not an attorney, a local attorney for them to even go to. So it's not even about money. It is about access to attorneys as well as not maybe having the $500,000 in legal fees to pay for all of that. I'm going to turn it back over to Olivia.
Great. So really in thinking about, we were asked to kind of talk about the sustainability piece. And so I think sustainability is always like, check, you know, have secure funding. And so we really kind of wanted to kind of better identify what sustainability means for us as a project. And so this was actually a good activity for us. So for us, really looking at committed partners, right, who are willing to self-fund this project so that we don't have to be chasing our tails, running around and trying to find funding. I think it's just really helpful. The last bullet, time and space for continuous quality improvement, that doesn't say quality, and deeper project evaluation. I think it's really hard to do that work if you're constantly growing, constantly looking for money, right? So I think that it's really helpful. 2020 has been a bonkers year for lots of reasons. And so we're looking forward to 2021 to be able to do more of that quality improvement work. The second one, we are sharing a pretty lean and mean legal team, right? So we need to be smart about growth and not just grow for growth's sake, to make sure that every partner feels like there's a balance between access and affordability. Right? I think that that's a hard balance that every MLP deals with, and it's a conversation we'll continue to have because we would like to grow, but we need to be really smart about it. We want to really make sure we're integrating the health justice partnership and health harming legal needs into our work at the PCA and across health centers to screen and intervene in patient level social needs, right? For us, our prepare work started with the health justice partnership, right? So we need to center this work and this data as we head into a value-based pay environment. We do not have a value-based pay environment. Other folks a question came in about, you know, what will Medicaid pay for? It really depends on the state. In the state of Montana, they're not paying for much. But we need to, as we move and prepare to go to that place, make sure that we have this data as part of it. One of the exciting things that we work really closely with our HCCN. If you have an HCCN, you should talk to them because they are smart and will make sure that you are building the system that you need in the future, not just the system that you think you need to build right now. So all of our health centers are getting onto Azara drives to really do that kind of data analysis. And so we are making sure that we're mapping all of our health justice partnership, our health harming legal need data as part of that onboarding with our sites, which is pretty exciting. I think I love and want every provider or every person who applies for a job at a health center to say, do you have an MLP? So we want improved health center team satisfaction and efficacy. On the flip side, I think that what's really exciting is I want every attorney who gets a job anywhere that's doing poverty law to say, and are you working with a health partner who has this kind of robust team structure to support that attorney in the same way? And so I think it's a two-way street. So if there's attorneys out there thinking, does it really matter? It really does matter. Callie tells a lovely story about the value of working with a patient and then referring that patient back in to the behavioral health team at the health center, like knowing that there's integrated behavioral health. And so that referral is kind of a two-way street. And so I think that really for us, the sustainability is more than the funding and thinking about how do we not only kind of grow this project in a smart way, but also have a little bit of that space to do the quality improvement and to do some of that evaluation stuff. There hasn't been a ton. MLP evaluation is hard, right? Everybody like wants to, in the beginning, we were like, and then we will have a peer-reviewed journal, right? We're going to connect this to that. We have high hopes of that in the future, but we're really looking forward to a little bit more space around that. And then we have one more slide. It's just our contact information if you want to chit chat more. That's it for Montana.
Thank you all. We do want to chit chat more. Our audience has questions. Olivia, I'm really glad you mentioned Callie has a story about legal services referring back in. It's something I just want to stress is that, you know, as you think about sustainability, think about the full loop of referrals and services that that partnership can provide. And so we started with how do you pay for this? Olivia, you started to touch on some of this. I want to see if I can get some feedback from Beth and Rakuya about the Indiana experience with Medicaid. Beth and Rakuya, I know that, you know, for managed care organizations, would you be able to share some remarks for folks asking about how legal services might be able to tap into Medicaid as a reimbursement payment mechanism for supporting the MLP?
Well, right now they don't pay, but I will say I was pleasantly surprised that one of them, as I said, came to us and has given us a chunk of becoming a vendor for them. And all they want us to do is give us a report on how many of their members we saw in a quarter, and they'd like us once a year to give a training on MLP for all their case managers, which I thought for what they gave us, it's a probably one of the best per hour rates that we've ever gotten, if I may say so. But don't tell anyone in Indiana that. But I think, and I think there was the comment about value-based payments. You know, that's kind of gone on hold this last year. We were working on two different grants, or two different contracts with our managed care companies. And I think that would have played into it if that had come to fruition.
Mm-hmm. And Rakuya, I don't know if you want to add to that, or if I want to give you a moment to add to any of that.
I agree with what Beth has said. We've worked with a managed care organization in the past. It was very early on, well, not very early on, but we've worked in the past, and some of the difficulty there was, I think, from their end, continuing to fund us. So what has happened with the HealthLink project, I think, is the way to go in terms of already connecting to an established MLP and working with the health center to fund it that way.
Mm-hmm. And folks are asking a little bit more, if you're able to share, what are the types of legal services? Did you have to define some of that up front? And Olivia and Callie, let me know in terms of like thinking down the road and looking at Medicaid, are you all being tasked with defining upfront what types of legal services the state Medicaid agency or the managed care organizations may expect for the patient population covered by Medicaid?
So I think for the Medicaid piece, we are far from that, right? We have a value added, it is like the lightest value added thing you can have that has, and right, COVID hasn't helped it. Even though it would be a really great time if you had a really robust program, right? With Medicaid, to have access to civil legal aid for Medicaid enrollees. Right now is the time to have it. So hopefully we can take some of this momentum of COVID and I think do some policy and advocacy work. I think that there are some little carve outs, right, where we're looking at tenancy support specifically within our Medicaid program and whether Medicaid could pay for tenancy support, right? That is like a teeny tiny piece that might touch on the medical legal partnership. But mostly it's probably going to be care coordinator staff and kind of social work staff within our health centers. So I think that it is for us far down the road and something we're building toward. But by the time we get there, when we're having that conversation, we're going to have really great data to make a really strong case, right? That's the goal. Yeah, does that answer the question?
It does, and I'll put in a plug. I probably should have prefaced this by saying that the National Center, I wanted to give our panelists a chance to chime in about exactly the same things that you all are thinking about in the audience. How do you better utilize those payment mechanisms? But just a couple of years ago, I can't believe it's a couple of years ago now, the National Center actually did begin to really dive into both quality aspects, quality payment, CMS's quality payment program that looks more at Medicaid, or excuse me, Medicare. And then later on, I believe they followed up with a series, a webinar and a resource document on how to tap into Medicaid financing. So we'll drop that link into the chat box for the audience to get a better sense of how you can look at both your quality payment program to help embed lawyers and use your MLP approach to hopefully boost your Medicare reimbursement, and then also tap into Medicaid financing. There's a long way to go. We even know that in North Carolina, Olivia just referenced looking at policy levers. We know that North Carolina a couple of years ago as well also got an 1115 waiver approved that specifically called out, explicitly called out legal services for their managed care transformation. So definitely take a look at the National Center's website for how the National Center is helping to push out some resources to begin assisting folks who are looking at gathering the data and making the case down the road for looking at those different payment streams. There's a question in here, two questions actually for Indiana. Number one, there was a request to Indiana to see if you all have any MOUs specifically to share. And then the second question is, could Beth give an overview of what the IU research showed would be helpful data to collect, or is there a document available to be shared from the research?
I think we can share our MOU, can't we? Or
As a sample, or
yeah.
We can, yeah, so we can share a sample.
And then the second one is, I was just trying to pull up, because this was early on, was 2018. And if it happened before yesterday, I'm old, so my brain. So yeah, I mean, we can, I think there was the final report, which I'm trying to see, but it did look like, we did a lot with looking at like their mental health status, and then if they needed MLP, and did that improve using PHQ-9s and GADs, and anxiety. So we did some work on that. But what I will do is I'll go back in here when I have more time and see exactly what our final where my final report is, and send it, and we can post it.
That'd be great. Thank you, Beth. Thank you, Supriya. The next question, and I know, Olivia, you also are, I know one of the things you wanted to really emphasize did was, you know, the gathering and analysis of data. So please feel free to chime in on, you know, research and evaluation aspects as it pertains to that question as opposed to Indiana. But there is another question here that I'll start with you, Olivia, first on, and see if you and Callie might be able to address. Do you know if for any of the MLP's services that are offered, if the patient or clients were placed on a sliding fee scale for, let's say, folks who, you know, in civil legal services, sometimes we talk about low bono sort of programming. So in the health center world, have you all seen or experienced, starting first with Olivia and Callie, any sort of sliding fee scale to help support MLPs?
So this is something that Montana Legal Services on our development team, that was we've talked about it a lot, and at least looked into it, but ultimately have just decided that we've found other ways to fund it because of trying to keep it relatively clean. So we have Montana Legal Services, independent of the MHJP, has a modest mean. So people who, not on a sliding fee, but if you qualify, people agree to represent you at a lower rate. And we certainly refer people into that program. But it's something that we've at least talked about, but then the mechanics of actually trying to get people to pay for their legal services, we've just decided that it's kind of too complicated, or kind of, as Olivia was talking about, having the capacity to develop that in a meaningful way. But it's certainly something we've discussed.
And then Rakuya, also being in this same civil legal services space, what has your experience been in this regard?
We've determined that it works best for our client base for it to be free legal services, just so that they're able to use those resources towards their health and their own needs. We have similar programs in Indiana where if we weren't able to accept the case for any reason, we do have some programs that are modest means, like Callie mentioned. But just from our standpoint, we found that clients are more receptive to our services if they know that it's free to them.
Makes sense. A question for Callie has been posed. Callie, do you keeping track of hours that attorneys spend on the cases, such as money saved in legal fees, into your MOU, or how do you collect that data?
Yeah, so that wasn't ever originally in our MOU. So we operated for 4 years and we never reported on that. When we became a sustainable model, it's something that our partners asked for us. They said, could you give us this information? And then so our MLP started a lot Montana Legal Services uses Legal Server, and they were developing a lot of tools to better monitor MLPs. And so we have really benefited from, I started with all of those tools, so they're really integrated into how we do our work. So any client that we come in, they're labeled under their organization of where it referred. And then we got a TIG grant to pay for some of our work. That's another area that we got funded. And so then Mallory Curran was our consultant on that, and she built us nice reports that easily pulled all that information. So she could pull by the funding code that we use, which is the MHDP funding code, and then also all of those organizations. So we report out to each organization specifically about how much time we helping patients specifically at their healthcare center. So it was a report that was available just because of our normal timekeeping that we do in Legal Server. So I didn't have to do anything differently. That information was there, and just building it out through our case management system. And it was all attorneys that have ever touched MLP stuff could be pulled from that because the clients were labeled under their MLP partner.
Thank you. Rakuya, any shared perspectives or experiences there?
We do something similar, I have to say, without being a commercial for Legal Server. We rolled it out the end of last year. It has made data collection so much easier than our prior case management system. So it allows us to pull reports by funding codes. It allows us to capture outcomes right there in the case so that we can pull it for reports. So we're still building reports and getting better data, and can't say enough about using the case management system to really collect the data.
And then if I could carry this one step further, because I know for folks like Beth who are, really trying to manage an entire health center and the finances involved, on their side of the data set and data that's being gathered on patients, any little change to an EHR can cost a lot. So Beth, in terms of really the MLP's gathering of data, any perspectives to share on how to account for that cost upfront?
Well, we're pretty lucky. We use Greenway so we can change all our templates. And so it was probably Jenny spending less than an hour and giving a login to Sarah. I mean, that's been, and it's a referral. We made it like a referral person. So as the docs go in and want to do a referral, they might see cardiology oncology, and medical legal partnership. And that
Mhm.
makes the difference.
It's something key that folks should keep in mind as they are, especially for folks in the planning stages or those who are developing their MOUs. Keep that in mind. None of us here work for legal services or the Epics or the other, or Greenway things that you mentioned, Beth, at your health center. So there are no conflicts here. We're just mentioning, as a matter of practical advice, what tools and resources are currently used to carry out the approaches that are working well for our expert panelists. I want to see if we have additional questions, and then maybe pose a couple of questions regarding budgeting. And so Danielle, I'm going to ask us if we could, I know there's a slide that just displays budgeting. I want to make sure the audience knows that we, in our toolkit, we do highlight some very practical sort of tools. So let's keep going, Danielle, to the MLP budget slide. All right, perfect. So what I just touched upon there is that, of course, you're going to be thinking about those resources and tools. And all of the folks on the expert panel today who are, really answering the questions and providing this practical advice through their experiences have gone into this with the budgeting lift, right? And they perhaps go through the annual budgeting aspects. So Rakuya, Beth, Callie, and Olivia, I'd like to just pose a question, really for the sake of the audience to learn. With the MLP budget that we've displayed on the screen, are there any successes or challenges as you were developing your MLPs that you now know in hindsight you would either devote a little bit more attention to or resources in as you look at these categories, the categories being legal staffing, your dedicated health center champions who are in leadership positions like Beth, any other staffing aspects like interpretation services, technology we just touched upon, travel expenses. Olivia mentioned for Montana during COVID, things have changed greatly. Rakuya highlighted the rural outreach aspects. And then there are the miscellaneous things that you may not have considered. Maybe you're holding a group visit and you need to simply print out educational materials. So what are some of your successes and challenges as it pertains to budgeting aspects of your medical legal partnership approach? Let's start with Montana.
I just kind of have two notes on that. The first is, I know Olivia talks a lot about this, and attorneys are much cheaper. Civil legal aid attorneys are much cheaper than doctors are, and I think people think that they're equivalent. So we're really transparent with our budget. Everybody knows it, and then that they are able to provide this service and afford to do it with other things. And then I think the thing that I'm really as thoughtful of as the attorney that's going into these health centers is there isn't any budget for our champions on the healthcare center side. They're not getting, except for sometimes with TIG grants, we can pay for a tech person or something, a few dollars here and there. But this is just an extra thing that our care managers, our case managers, our social workers, everyone they get told that this is now also part of their job. So being really cognizant and respectful of that time and making sure that the work that we are asking them to do for these patient clients, that we're acknowledging that it's their time and making it as easy as it can be. And then sometimes just apologizing for being annoying about getting all the forms signed and all of that stuff.
Thank you. Olivia, would you like to add to that?
I would just say we can't say it enough. I think that one of the fun parts of my job is having what sometimes feels like awkward family conversations about money. But I haven't always worked in healthcare. I think that healthcare has more money than legal aid, right? There's just, there are, health centers, I just think that it is super helpful to have money conversations with really tangible dollars, because it's a great deal, right? To get a civil legal aid attorney in, and to just, if you don't have that as part of your culture, I think that's one of the biggest things. Is it sometimes feels awkward, and there's something beautiful about that. But I think figuring out how to talk about money openly and who can get it. And I think that's just one of our biggest lessons learned.
Mm-hmm. Beth and Rakuya, if I could, within the framework of this MLP budgeting, I think some really great questions just came in about, how COVID, how and whether COVID has presented any challenges regarding how to make your pitch. Let me start first with one of the questions, a slightly different question that came in here. Sorry, there's some really good questions that came in, so I try to strategically weave them into the conversation here. With this MLP budget in mind and on the screen, if you were looking at a 2-year, 3-year fellowship for your legal staffing needs, does your funding strategy or approach change when you are looking at that more temporary or cyclical legal staffing?
For me, it would, because we want to be able to hire staff, but it's a little difficult sometimes to bring on someone if they know that their position may be 2 years or so. So we would look at, maybe instead of having one lawyer and a paralegal, maybe starting out with one lawyer, and as we build our kind of funding, adding the paralegal once we can show the success of the MLP, and then also really focusing on the product lines that have the most need, rather than maybe making it an entire health system by focusing on those departments or those locations that are seeing the most requests for legal needs. We're able to kind of have the data that supports a long-term MLP.
And so speaking of addressing the specific need that comes up, now I will ask the COVID related question that came in. How can you present an MLP, or how can you build an MLP in response to COVID? What is the best way to pitch an MLP at this time? Thinking of what we hope will be a very, very temporary situation, but we very well know that going into COVID, there was housing insecurity that MLPs have always addressed. It's been exacerbated by COVID, and it will soon, as we'll see after the moratorium sort of fall away and end, that those sorts of issues will persist at an exacerbated level. So how do you then make the pitch for an MLP addressing COVID right now, especially a new MLP? And then as one person noted, with respect to private funding, and I know they posed that question to the National Center, but I'll take a little stab at that, but I really want to tap into our experts, their experience here. As it pertains to private funding, what is the approach as it relates to those philanthropic funding approaches? Are they coming from endowments? Are there conditional funding approaches that maybe one could go after, sort of tagging on to the COVID related response or question that was posed? So I don't know who wants to tackle that first.
Let me try, because a lot of our United Ways, our community foundations came out during COVID, and they wanted to give us money to do something. I mean, we had gotten our federal dollars to do testing. We had the PPP loan. We had a lot of stuff, but being able to continue, and let me say, and I don't know if it's the past question or this one, but we had already started to move before COVID to more of a remote. When we started talking about a learning, we actually, and we also transitioned about a year ago to a different attorney. The one we had was amazing, but she was homesick for Louisiana, and Northwest Indiana, middle winter, made her want to go back to Louisiana. I don't know why, but she did. So we got a new one, which, by the way, it couldn't have happened. The person actually had a summer home, probably 10 minutes from one of our clinics, and she wanted to be up on the lake. So, I mean, I think that all worked out like amazing because we're doing the right thing. But I think, again, trying to you got to understand what an MLP really is and the social determinants. And I always say we have an MLP and people look at me and I always go, it's not criminal, folks. It's about everything else that people have that interferes with their ability to improve their health. You know, mold, that was one of our first ones, mold. So being able to take that, for us, it was unemployment, people not being able to get unemployment, not, you know, having a safe place to live, even though they were under that moratorium on eviction, somebody trying to do an eviction. Those were the things, and it made such a good story that most of our foundations, you know, just said, okay, here's 10,000. And it doesn't sound like much, but when you, for us, if you have 5 counties and you get 10 or 20,000 from each county, it all adds up. And so I think just trying to understand what the MLP is and seeing how you can tug at that funder's heart is pretty amazing. And COVID allowed us to do that.
Mm-hmm. Agreed. Callie and Olivia, any similar experiences with, especially those private foundations approaching you? I know the question that came in from the audience is a little nuanced, and they're looking for strategies and thoughts on how using the conditional private funding to run a pilot initially may then allow potentially for some flexibility with regard to using the remainder of funding after you've reached and met those goals to continue to carry out your MLP. Any thoughts on conditional private funding or strategically addressing those private funders in general?
I would just say that.
Quickly.
Sorry, Kelly. I'd just say I think that funders are really interested in MLPs, right? I think that everybody's talking about MLPs, I think due in part to the center's great work. I think that it now is a really great time to talk about MLPs. I think that I think it also looks like a good deal to funders, right? It's depending on how you're structured, like it's not that much money compared to other interventions. And I think with COVID, I think the timing is right. What I think that in Montana, we see a lag on impact on like national economic trends. So we are preparing ourselves, because I think some of the worst of what we're going to see is going to happen in 2021, right? And there is a relationship that's already built that like can respond really quickly to respond to like 3-day eviction notices, which I just think is an incredible thing with that funder. Like everybody recognizes where we're at, and if we don't have to recreate this every time there's a disaster or a pandemic or an emergency, like this is a super helpful program to exist to respond immediately to the needs of the most vulnerable Montanans. So I think now is a great time to try to sell an MLP to a funder. I would just say don't over project on your referrals, aim low and far exceed them. I know we far exceeded our referral numbers and everybody was happy with our initial pilot grant. Callie?
I'll very quickly just echo that I think that it's been such a highlight, especially around housing. Housing is healthcare, and how important having a legal team. Like when the CDC is like, we cannot have public health if people are outside of their home. Like I think that we can sell that. And now we've gone back to our private funder who initially funded MHAP, and now they're funding our eviction relief program. So we've been using those keys to kind of expand what we're able to do, those relationships. And then on a much more minute level, it's been really helpful during COVID for us to be able to use our healthcare partners to get out information. So like making sure that people are getting in with we have 10 days for their unemployment. And then also we now are helping everybody who is getting an eviction, you can get an attorney. And so we use those communication venues or lines that have already been open to then get MLSA out into those communities. So that's been really helpful for us. But I think that those are tangible things that you can use to sell an MLP, is that your community will be healthier with having this partnership.
This is great. So we're right at the end of our office hour portion here of the entire presentation today. A couple of last questions came in. We'll definitely keep track of those. Actually, let's roll right back, Danielle, right before my contact information, because I want to, number one, thank everyone who hung out with us here today for the presentation, as well as time to really pose some really substantive, meaningful questions to our experts from the field who have really helped to feed into the very information that the National Center is being able to gather to create these very resources that you all are utilizing. With that, then also let me thank our expert panelists today, Rakuya and Beth from Indiana, and Callie and Olivia from Montana. We really could not have done this without you. And we know that we'll be able to continue to count on you in the 2021 year of metamorphosis, as I like to put it now, to really help folks improve their communities, improve the health of individuals, and really address, those real drivers of health, those social determinants of health. Lastly, for folks who are looking forward to 2021, as we all are, we do have upcoming trainings to really dive deeper into the rest of the toolkit. We'll be talking about how the health centers as healthcare providers really do benefit from medical legal partnerships in their workforce development programming. How do you then go into the screening and referral and service delivery workflows as you begin to apply the approach? And then finally, how do you move way upstream, right? You're not forgetting about those individual and direct services, but you're going further upstream to look at those policy level approaches. And we have examples of that. So we're really looking forward to continuing to meet with you in the new year. I wish you all, thank you again for joining us, but I wish you all very happy holidays. Please stay safe, and we'll definitely see you all in 2021. Thank you, everyone, for joining us today. Take care.